This video is part 3 in our 5-part series on why mid-back pain between the shoulder blades usually isn't a rhomboid problem. In the video, I cover the following: a breakdown of the supraspinous ligament in the mid-back, palpation and treatment demonstrations of scar tissue in the supraspinous ligament, and tips and tactics to get long-lasting results. For those of you who don't know me, my name is Dr. Matt Maggio, and I am a non-surgical expert in chronic pain treatment, specifically for headaches, neck, upper back, and shoulder issues. My focus is on finding and fixing nerves that become stuck to muscles with a glue-like substance called adhesion, also known as scar tissue, and then reducing inflammation from chronic pain naturally without the use of medications or injections. This leads to a big increase in flexibility, functioning, and long-lasting pain relief. I'm also the creator of the Peak Method, where we teach massage therapists a new injury treatment system that eliminates the frustrations of not getting consistent results. It produces long-lasting pain relief for their clients, all while working 50% less. All right, so this is part 3 of 5 in this video series. If you haven't watched the original installments, if you're watching this on YouTube, I'll link it up top. Anywhere else, it'll be listed down below in the description box below. But why pain here in this photo usually isn't a rhomboid problem. This time we're going to be covering scar tissue formation, also known as adhesion, in the spinal ligament. So let's get right into it. So you have this ligament in the back part of your spine that has a fancy name, which is really awesome. It's called the supraspinous ligament, which means above the spinous processes. So it really goes from the top part here in the cervical vertebrae all the way down to the bottom of the sacrum. For anatomy standpoint, up top, basically from C1 to C7, it's called the nuchal ligament, and then it becomes the supraspinous ligament as you go down. For this area, what I'm really going to be focusing on is really from about T1 to about maybe T5 or T6. This is where I'm going to find a lot of that dysfunction in that ligament, especially if they're presenting with that mid-back pain that looks like a rhomboid problem. So function of the ligament, the supraspinous ligament is very important in stability, in movement, in motion, and a lot of the muscles in the posterior part of the back actually anchor to the ligament and get a lot of their force production and drive from there as well. So it's really, really important in so many movements, especially like flexion of the spine, extension, and really just allowing everything to biomechanically move how it's supposed to. So why does it develop adhesion? So I always talk about adhesion. Adhesion's like this glue that gets inside the ligament. Basically, over time, when people are just sitting in bad postures, you know, you look at everyone just staring down at their phone, their head is like parallel to the ground, spending all day on their computer or their phone, puts a lot of stretch into that ligament. When it gets that stretch, it doesn't get enough blood flow and oxygen, and then the body thinks there's an injury there and starts to lay down. A lot of that adhesion gets inside the ligament, and then the ligament can't do what it's supposed to. So clinical signs first is you're going to just see just some decreased range of motion. Then you might see some pain with movements. You might see some weakness in the area. You might even also see like some extra inflammation build up in there as well because the tissue's really getting beat up. But mostly it's just going to be like a painful movement, especially they might say, hey, when I first get up and I try to drop my head to the ground, doesn't feel good, feels stiff. And I always kind of grade it on a scale of like 0 to 10, 0, no pain, 10, you wouldn't care if we just cut that area off. Usually when there's adhesion in that area, it's like anywhere from like a 2 to 6, sometimes a 7, but nothing like awful, but enough to get your attention and let you know that there's some issues going on in there. So the first thing I always talk about is we can't fix a problem if we can't find it in the first place. And a lot of people ignore this ligament, but it's so important. And a lot of people don't even know how to actually find it. But if this ligament isn't working correctly, you can do all the treatment you want in the muscles, around the nerves, all the work, but these muscles aren't going to be able to do their job unless this ligament is properly addressed. So the first thing we want to do is we want to be able to accurately find where the dysfunction is in the ligament. So what I want to include first in the video this week is a detailed functional test and palpation of me checking this area out and seeing where it is. So I'm going to link that up right now. So this is what we're going to call lower
cervical spine thoracic flexion test, because basically we're going to go from about C6, C7 all the way down to T4. And this area is so dysfunctional in pretty much every human being. So the first thing I want to do is I always want to assess this in a chair. That really helps things stay nice and relaxed, and you want a chair with a nice solid back. The first thing is the client position is going to be very important. You're going to have them put their legs together, feet together, kind of like what we've done in other tests. And the first part of that motion, what you're going to do is have the client just drop their head straight down, but you want to make sure that their back stays in contact with the table. So we do that first one. Now we do that again, drop the head down, and this is where you go in and ask the important questions. Where do you feel the pain? What does that pain feel like? And how intense is that pain? So now we have that data. Now we'll get our pencil out again, and this is going to really help. So come real close on this one. So this one is really key to get a picture of. And a lot of people, and you'll see this specifically in women, they get this outpouching, or what's called a granny hump. And this granny hump is starting to happen because there's a lot of dysfunction in here. So we're going to take the pencil and get it lined up just like this. So this is C7 right where it goes. And you're going to put the pencil in here, and you're going to kind of go down and look for areas where it's really flat. And what we're seeing now is it's very flat all the way through here. We should see that only that 3 is touching, but you see in here, it's going from the 2 all the way down to the 5. So there's a lot of dysfunction in there. And what it does is it puts more pressure up in this region. Now this test can be a little, this test can actually create a lot of symptoms, so you don't want the client to hold into that too long. So once you've established the area where that dysfunction is, where that flatness is, that's when you'll go into your palpation. So you'll have the client drop down just like that, and what I'm going to be doing is holding their head here. This is very important, and I'm going to be pushing back on the chair. That'll help everything settle down and not feel so inflamed. So I've located that area where that problem is. Now what I'm going to do is get in here and palpate right on that ligament, and this is called the interspinous ligament. I'm going to work my way down, and I'm seeing that there's a lot of tension in there. When there's scar tissue, it just doesn't want to move. Then based off of that, I'll start to palpate around the erector group in there as well. And usually when you find some flatness there, you're going to find some dysfunction in this supraspinous ligament, which in turn is going to put more pressure down on these erector groups as well. Now the key here is really holding this in place and helping support the head. If you let the client just kind of hang out for that in a long position, it's going to flare up a lot of things. It could actually put some pressure on the joint and the disc and the neck. So the key is the motion. You just drop it down and you support it and you put it back just like this. And this one is really key, where you can get in there and put the pencil down, and in that short moment when you're putting the pencil down, you can hold it in there, and that's when you're going to get out your cell phone or your camera. I would recommend a cell phone, and you're going to take that picture from the side. And when you take that picture from the side, they're going to be able to see that pronounced hump, and they're going to see all that flatness in there, because the picture really gives a lot of data and gives an idea of what's going on.
So just a couple take homes from that video is just slow down. You know, so many providers, and I did this myself over the years, is we're just so quick to want to jump into treatment and treat everything instead of doing the right treatment. When you slow down, you really narrow in with your palpation. You're not going to have to do so much treatment. It's just going to be more effective as you go. So I always say, in order to go fast, you first got to start by going slow. Next is going to just be a treatment demonstration of the supraspinous ligament. I firmly believe that the only way to effectively treat this is with some type of instrument. You're going to see an instrument in the video that we use specifically. If it's an instrument you're interested in, just drop a comment in the section below or send us a DM and we'll get you a link to that. It's pretty affordable as you go in there and buy it, but it's the best one that I found so far to actually go in there and clean that area up. So I'm going to link that video up right now.
So now that we identified the area where all that flatness is, we backed that up with palpation and identified scar tissue. The first thing that we want to do is actually apply some instrument treatment on the ligament in the neck. So setup is still exactly the same. You're going to drop their head in just like that. And the key here is you're going to be pushing back into the chair. That allows everything to just relax, because if they're hanging out by themselves, it's going to be very inflamed in there. So that's going to be what you're going to do when you do the treatment itself. So let it go back up for there. You're going to get your lotion and you're going to get your instrument. So always want to use lotion. You always want to use lotion in here because it gives better glide. So you get the lotion on there just like that. We've identified that's the area. So now we're ready to apply the treatment. So the first step is you're going to just have them flex down just like that. You're going to push in just like that. And then the way we're going to look is we're going to do some landmarks to see where the spinous is. So this is C7, this is T1. And in between there is where the ligament is. You'll feel it. You can kind of wiggle it around and get that to open up. And where it's really bad is right in through here. So I know that that scar tissue's there. What I'm going to do is get in there with the instrument. I'm going to back that up, go here, and I'm going to pull up in there, and I'm starting to feel for some grit. And that grit is that scar tissue. And each time I go through a pass, I drop the head a little bit more. You're going to see that it opens up each time. It's going to give you more access to deeper layers of the ligament, and it's going to open up even more. You're going to do about 5 to 7 passes on each area where you find that grit and get that to open up. That's going to really free up that area from what we see. You're going to see the instrument jump here. So right here is one of the spinuses, and here's the other one. And if we start below the spinous, it kind of pops off, and then we sink back in. That sink back in is the area where you want to treat it and really get that to open up. And it's not a long distance from where we go, but it's really going to take some of that pressure off of that area as well.
So once again, you can see everything is deliberate, it's focused. You know, a lot of times when people are doing instrument work, they just do way too much work. So a couple of treatment errors that I see when people are treating this area. First is you must use the instrument with the correct vectors. You know, that thoracic spine is a little different because it has what's called more of like a kyphotic curve as opposed to like a lordotic, like the cervical and lumbar spine. It kind of goes forward and down as you see that. I'm sorry, back and down. And those spinuses are kind of pointy and then they drop off a lot. Biggest errors I see with people when they're treating this is they don't really accommodate for the curve of those spinuses in there, and they actually just jam it up there, and it kind of doesn't feel good, and it hurts like hell and just irritates the area. It doesn't actually break down the adhesion. Next is you gotta actually go back and clean up the nerve entrapments first. I covered that in the first couple of videos, especially accessory nerve and dorsal scapular nerve, because if you go in and just treat the ligament first, but you don't fix the nerve, those patterns are going to continue to come back. So go in and clean up the nerve entrapments first, then go in and clean up the ligament as you go, because if you just get the ligament first, it's just going to be what's called a reflexive change, where they temporarily feel better, but you didn't actually fix anything. And then next is just treating, I always like this word, haphazardly. With the instrument, just going in and scraping. I hate that term when people are like, oh, I got some muscle scraping. You're not scraping it. It's deliberate. It's very focused, and you want to slow down and do it. You know, so many people over treat with the instrument. They beat the hell out of the tissue, and they think, oh, because it's bruising or it's red, that they did something. No, you just did a lot more damage. So being deliberate, being slow, getting proper depth, backing off, tension, going slow, no more than about 7 to 10 passes on that area per area of like palpable adhesion. And then, like I said, too much treatment dosage, just doing way too much, just beating the area up can cause a lot of issues. This ligament is really important to address and see and fix. But like I said, you got to clean up the nerves first and then work your way down as you go. That's how you're going to get those longer lasting results. That's all I got in the video. I appreciate you watching. Share any insights you may have gotten in the comment section below. I try my best to answer any of these questions and, you know, engage with people and try to help the best that I can. Next is you could just do me a solid and share this with other providers that you know might help. You know, my goal is to help massage therapists just do better work, better quality work, and give better care to their clients so we can help more people so they can stay away from the traditional medical model of pain pills, injections, and surgeries, which only make things worse. And lastly, go and download our free training modules, and that really get into the idea of like critical thinking, slowing down, teaching you how to become more of a solutions provider as opposed to a service provider, and learning how to start by going slow so you can eventually go fast. And we actually cover this ligament in that training as well. Links to download that and get instant access are wherever you're consuming this video. I appreciate you watching, and I will see you on the next one. Bye.